A very good afternoon to all present. I shall be presenting from the Department of Pediatrics for the clinical combined rounds today. We shall present to you a case from Unit 1, a case of multi-system inflammation navigating through the tortuous path. I present to you a case of a child, 13 years of age, a boy, who presented to our OPD with the complaints of fever, pain, abdomen, and vomiting, and episode of seizures 5 days back. I present to you a case of a 13-year-old boy. He presented to us in the OPD with the complaints of fever, pain, abdomen, and vomiting on and off since 8 months with marked weight loss. And what prompted his visit to the OPD was an episode of abnormal body movements 5 days back. So, summing it all up together, the parents thought it was time to visit a higher institute. On probing for further complaints, there was no history of any swelling around the eyes, in limbs, abdomen, or face. There was no history of any rash, oral ulcers, joint swellings, or joint pain or restriction of movement. The child did not report any history of cough, chest pain, or any difficulty in breathing. There were no bleeding manifestations, blood in the urine, or any difficulty in the sensorium or any contact with tuberculosis. Going through briefly through the past history of the child was apparently well until a year back when he encountered an episode of parotid swelling and fever. It was diagnosed as mumps and treated at a hospital locally. Thereafter, the child remained well until a month when he again had episode of fever with pain, abdomen, and vomiting, so much as to take him to a nearby hospital. He was evaluated there and found to be COVID positive. On evaluation of the inflammatory markers, it was found that they were raised, and also the child had suggestive symptoms, and hence he was treated with IVIG and steroids. During the same admission, he was diagnosed to have a focus of the fever in the form of a UTI. It was pseudomonal UTI and was treated with the sensitive antimicrobials in the same setting. The child remained well again after about a month or so when he developed a similar complaints and was hospitalized and evaluated further. The parents reported since they were not satisfied with the management, they left against medical advice and thereafter followed with complementary and alternative medicines, after which they reported that there was some improvement in the above symptoms and the child remained fever free and other symptoms were also abated. But then again, around November, there was a recalcitrance of the symptoms, and the child had to be again admitted in a nearby hospital. On evaluation, he was found to be pale with anemia and hypertensive. And further evaluations also revealed that he had evidence of renal dysfunction. The urea and creatinine were markedly deranged, and the child was referred to a higher center for evaluation of the clinical picture so far. While they were due to visit our OPD, the child through an episode of seizures, which was managed in the emergency. And with this referral note, the child came to us in the OPD for further evaluation. In the OPD on examination, the child was found to have high BP records, hypertensive records to the tune of stage 2. He was sent to the emergency for the same, where he was managed. The child was admitted for further evaluation and it was found that the child had unremarkable general physical examination but for the presence of pallor, persistent hypertension, and some thickened non-tender temporal vessels. And hence that brought us to our realm of possibilities. Considering the history of fever, pain, abdomen, and vomiting on and off throughout the period of 8 months and a significant weight loss of 11 kgs, the possibility of infection, likely tuberculosis, was considered. Also, ancillary possibilities of human immunodeficiency virus and infective endocarditis was also considered. But the prominent feature of hypertension led us to think of inflammatory disorders such as vasculitis, including polyarthritis nodosa or some ANCA-associated vasculitis and systemic lupus erythematosus. Considering the constitutional features, the possibility of malignancy was also kept on the cards, predominantly such as lymphoma. At the outset, the initial investigations revealed that the child was anemic with the neutrophilic leukocytosis, with a normal platelet count and an unremarkable peripheral blood smear, but for the presence of microcytic hypochromic without any schistocytes. The blood chemistries revealed renal dysfunction. The urea and creatinine were markedly deranged. The rest of the chemistries were although unremarkable. The urinalysis revealed that the child had proteinuria, and the viral markers were found to be negative. Markedly so, the inflammatory markers were elevated, which was something eye-catching. We further evaluated the child for renal dysfunction and found that on ultrasound kidneys and Doppler examination, the bilateral renal picture was a bulky kidney with raised ecotexture and loss of corticomedullary differentiation. The arteries were normal at their origin with the flow abnormality in the form of Pavas stardust in the bilateral segmental artery. The above findings prompted us to consider a vasculitic pathology, and consideration was given for the performance of a CT and MR angiography. I would now like to invite Dr. Ankit from radiology to come and discuss the findings of the CT and the MR angiography.
Good afternoon, everyone. So, since there was high index of suspicion for vasculitis, a CT angiogram was performed on 31st December 2021. And what we could see on the CT angiogram is that on the axial arterial phase images, we can see that there was diffuse involvement of the visceral as well as the muscular branches. So, in this image, we can see that there is this beaded appearance, that is alternate stenosis as well as dilatation of the intercostal artery. Then in this lower image, we can see that there is underperfusion of both the kidneys and the left renal artery is focally dilated in the middle third. However, in the proximal third and in the distal third, that is beyond the hilum, the left renal artery is not opacified. Similarly, the right renal artery is not opacified in the entire extent with the underperfused bilateral kidneys suggesting renal involvement. And in these two images, in the coronal MIP images, we can see that there is diffuse involvement of the visceral arteries, namely the branches of the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, showing this characteristic beaded appearance as well as multiple focal dilatation in the end branches, which are the aneurysms. Lower down, we can see that there is involvement of the muscular branches of the femoral artery, which also shows this characteristic beaded appearance. This is the cinematic render technique images in which we can better appreciate all these vascular changes. In the lung, we do not see any abnormality. However, in the heart, we can see that there is focal dilatation of the left anterior descending artery. And in the abdomen, we can see that there is almost diffuse involvement of the branches of the celiac trunk. So the branches of the common hepatic artery, the right and left hepatic arteries show this focal dilatation and narrowing in the distal half, as well as we can see multiple aneurysms in the branches of the superior mesenteric artery, inferior mesenteric artery, and this beaded appearance of the muscular branches of the femoral artery. Is the sagittal MIP images showing this involvement of the internal mesenteric of the internal mammary artery, the branches of the superior mesenteric artery, the branches of inferior mesenteric artery, and the branches of celiac trunk, showing this characteristic beaded appearance and these multiple aneurysms. These are the set of images showing the involvement of the visceral arteries in the upper abdomen. These are the branches of the hepatic arteries showing this alternate narrowing as well as dilatation having the beaded appearance. And in this image, we can see the involvement of the splenic artery having these multiple aneurysms. Since there was also episode of seizure and multiple abnormal body movements, we also did an MRI brain with MR angiography on 3rd January 2022. In this, we can see that there was focal T2 and flare hyperintensity changes that were seen in the subcortical white matter in the bilateral frontal lobe. However, they did not show any diffusion restriction or any contrast enhancement. Based upon these features, we suggested whether it can be any vasculitis related ischemic changes or all ischemic changes. Then the MR angiography showed this involvement of the branches of external carotid artery, namely the superficial temporal artery, which again showed the characteristic beaded appearance. There's alternate areas of narrowing as well as dilatation involving the bilateral superficial temporal arteries. This image, we can see that there are similar changes also seen in the vertebral arteries. So based upon the CT angiogram and the MRI brain and MR angiogram, this characteristic appearance or the abnormality is seen in the visceral as well as muscular arteries with the sparing of pulmonary vessels. We first suggested a diagnosis of a vasculitis, most likely the polyarteritis nodosa. One of the other possibilities is a connective tissue disorder, maybe Loeys-Dietz syndrome, in which there is facial dysmorphic features also present. However, this patient did not have any facial dysmorphic features like hypertelorism or bifid uvula or cleft palate. So the possibility from our side was a vasculitis, most likely polyarteritis nodosa. Now, Dr. Pujita from cardioradiology would be discussing the digital subtraction angiogram of the abdomen of the patient.
Considering the above angiographic findings, we were likely show that the diagnosis is polyarthritis nodosa. I would just like to touch upon the criteria of diagnosis of polyarthritis nodosa. It is the sine qua non is having evidence of a necrotizing small to medium vessel vasculitis with angiographic or histopathological evidence of the same, and at least one and more of skin involvement, myalgia or tenderness, or hypertension, or peripheral neuropathy, and renal involvement. As you can see, our patient had two of the above and significant evidence of necrotizing small and medium vessel vasculitis. So that is how we came to a reasonable certainty that the patient is a case of polyarthritis nodosa. I would like to touch upon the course of stay of the patient in the hospital. We were managing the child for deranged renal function and hypertension by supportive management with hemodialysis and antihypertensives. There was an issue of transient subacute intestinal obstruction for which the pediatric surgery team had been involved since the early on. The CT and MR angiography had been undertaken, but thereafter the child developed a new issue, that is a GI bleeding. There was melena and hematochezia present, which was so significant as to require almost daily or alternate day blood component support in the context of hemodialysis. And we were at loss as to what is causing the significant melena and hematochezia. For evaluation, a colonoscopy was undertaken, and we could not visualize any focal bleeder. The entire mucosa was covered with blood. And considering the challenge of repeating the investigation, because the preparation also caused significant bleeding, we decided to undertake a digital subtraction angiography in order to find a bleeder that might be amenable to intervention by embolization. I would herein like to invite Dr. Pujita to discuss the findings of the digital subtraction angiography.
Good afternoon, everyone. As the patient presented with GI bleed, we have done angiography, and we had in mind if there is any active contrast extravasation or bleed, we would embolize the bleeder. So here we can see the flush iotogram. In this flush iotogram sequence, we can see there are, as our radiology colleague has already discussed, there are multiple microaneurysms which are arising from the visceral arteries. And then we performed a selective angiography. This is the selective angiography image of the celiac axis, where we can see the similar findings of multiple microaneurysms from the celiac arteries, gastroduodenal artery, and also from the splenic artery. And this is the selective angiographic image of the superior mesenteric artery, where we can see in the superior mesenteric artery, from the main superior mesenteric artery, so here we can see from the distal main superior mesenteric artery, there are multiple microaneurysms, and also from the ileocholic and right cholic artery, and from the ilial and jejunal branches also we see a number of microaneurysms along with the segmental occlusions and constrictions at places. We couldn't find any active site of contrast extravasation or any leak from any of the visceral arterial branches. And also this is the selective run of inferior mesenteric artery also, which is showing the similar findings of multiple microaneurysms and occlusions, but we couldn't find any site of active contrast extravasation. So we also performed provocative angiography, that is we give intraarterial injection of a vasodilator like nitroglycerin in order to see any obscure bleeding that may be masked by spasm of the arteries. After performing provocative angiography also, we couldn't find any active site of active extravasation. And there are multiple arteries which are involved, so we cannot perform a preventive embolization also in this case, as multiple arteries are involved. So this is about the DSA.
Since the DSA did not give us any local bleeder which we could identify and embolize, we set up a multidisciplinary meeting and undertook the meeting to address the main question, how to tackle the ongoing bleed, which was life-threatening. So the pediatric nephrology, gastroenterology, rheumatology and surgery teams sat together, and the decision taken was such that we need to escalate the immunosuppressive therapy in order to hit hard on the primary pathology itself, that is polyarthritis nodosa. Secondly, although an elective procedure could not be taken up at this time, preparedness for an emergency surgical intervention would be advisable in case the child developed any complication requiring an emergent surgery. So, as luck would have it, the child unfortunately developed abdominal distension, features of obstruction, and the X-ray was suggestive of a perforation. I would like to hand over to Dr. Ranjan sir for his elaboration of the pediatric surgery team's efforts.
Thank you. So at this juncture, we were with the patient, probably polyarthritis nodosa, with extensive vascular involvement of the GI tract. We could not had any focal area. So surgical intervention was definitely not in the cards. And this X-ray was 5 days after that multidisciplinary meeting that was held. And at this juncture, we had no other option but to go in. So at this point, we had several challenges in our hand. Which one to? Okay. So what findings were we expecting and what procedure to offer and when to intervene? Of course, there was this was the only time we had to intervene. So procedure wise and the findings with in the back of the mind, we had the investigations. We thought let's explore and find out exactly what's the scene and we would decide accordingly. And the intraoperative findings were unlike the preoperative investigations was very classical of acute perforation peritonitis. We didn't have any telltale features of polyarthritis nodosa, any feature of bleeding or thrombus, or the bowel looked absolutely normal throughout from the duodenojejunal junction to the ileocecal junction. So, however, this is just a schematic representation of what was seen. Gross pus all around in all the compartments. There was a perforation at the jejuno-ileal junction, and this was partially walled off by the collapsed distal jejunum, the ileum, and it was occluding it. So with that, we had no other choice but to resect that segment. Okay, sorry, resect that segment, and the procedure what we had in mind is of course to do a stoma, but with the position being a very high in the bowel, we thought managing such a child with dyselectrolytemia in the post-op and deranged electrolyte functions, we would rather take a chance, but possibly in the hindsight, this didn't help us. Because the child was already on various immunomodulators and immunosuppressants, the child had a leak which we had to re-explore, and this is the current condition: a stoma, a higher ileojejunal junction with high output, and is currently awaiting further workup for stoma reversal. Thank you. I think pathology, Dr. Hannah, to take over.
I'll be discussing the gross and microscopic findings of this case in brief. So these are the gross images of this case. On the right, we can see on the external aspect that there is considerable serositis. Exudates are covering the serosal aspect almost entirely, and the mucosa is edematous. Here we can see changes of acute ischemia in the form of loss of cellular details on the villus tips, and then there are some small microcrypting also. The serosal aspect showed extensive organizing serositis, and this is the mucosa, which is showing deep ulcers, which are growing into the muscularis propria as well. This is the serosal aspect, which is showing a lot of congestion, organization. There's a lot of fibroblastic proliferation. All of this was suggestive of a heel perforation. And then the ulcers also showed some large nuclei within the base of the ulcer, which on higher power we can see some nuclei which are showing intranuclear inclusions. So this was suspicious for CMV, and an immunostain for CMV was performed, which was positive. So along with the perforation, the patient also had an underlying CMV infection, which was possibly due to the immunosuppression that was going on. In addition to the above findings of acute and chronic ischemic change, The vessels were showing the presence of hemosiderin deposits and a lot of remodeling in the form of intimal proliferation, occlusion of the lumen, and formation of recanalizing thrombi. This vessel is showing in the pseudoaneurysm. There is a marked intimal proliferation, mucoid intimal expansion is there, and on special stain we can see that this is the elastic lamella, which is completely destroyed in this region, and there is intimal expansion outside the vessel wall. So this is a pseudoaneurysm. All these features can be suggested. With these features in mind, we gave a diagnosis of acute on chronic ischemic change secondary to polyarteritis nodosa and concomitant CMV infection. I'll hand over to
After the procedure, we were able to add diagnosis of polyarteritis nodosa histopathologically, and we came to with a new problem, that of CMV infection. We had histopathological evidence of the same, for which we started with ganciclovir therapy and went on to Valgan as a child tolerated orally. The issue after the procedure were that the child had a course of fulminant sepsis on and off with incumbent cytopenias, which precluded us from escalating our immunosuppressive therapy for the primary disease. On and off, the child had episodes of sepsis, which required antimicrobial therapy, even so much as to escalate to colistin, and also intensive care support as and when was required. Currently as well, we are unable to institute immunosuppressive therapy in light of the ongoing sepsis and cytopenias, for which a variety of possibilities were considered, leading among which was sepsis. So it was a challenging case nonetheless. The renal morbidity itself and the dialysis requirement of the patient was a big challenge to his nutritional requirements and made the fluid management a very precarious issue. Immunosuppression it was interrupted by sepsis and still remains an issue. We are unable to hit hard on the primary disease because of the same. The high output stoma and the short bowel further complicated the overall health of the child and the nutrition. And critical illness itself had its own complications. For example, critical illness associated neuropathy, and the child is still struggling with the same. Although we had sent genetics in hopes of getting a monogenic variant of polyarteritis, which we could address specifically, but the genetics did not yield anything beneficial in that sense. It rather only confused us more. So after having discussed these challenges, I would like to hand over the discussion to Dr. Rikagri regarding the childhood polyarteritis nodosa and the new avenues in the same. Dr.
Everyone for presentation, and I'm sorry for the technical glitch, and in interest of the time we are just skipping the discussion. So we chose to present this case because of the complex nature that we have seen, that though childhood PAN per se is a very rare entity, but we have seen that in this very index case there was multi-modality involvement was required for dealing this complex case in terms of the morbidities associated with the childhood PAN, particularly the renal and the GI perforation. Though there are series with GI perforation and renal involvement in PAN per se in adults also, but in pediatric the literature is scarce. And I think for suspecting vasculitis is important that in this very case we have seen that the child was lingering with a low grade fever or fever weight loss for quite few months before the diagnosis of PAN was offered. So often we need to keep a high index of suspicion for diagnosing such inflammatory conditions like vasculitis. So this is the key message that we would like to give to the audience, and the house is open for any questions or comments. It's what negative, sir. Yeah. It's actually, again, this is important. If you look at the initial course of the child, that the child was managed as multisystem inflammatory syndrome related to COVID-19. But I think it was just probably because there's a diagnosis of exclusion, and often the children are overdiagnosed with this entity. And as we have seen that it has given a brief relief because of the IVIG and the steroid that might have helped in the PAN per se, but subsequently the child had thrown the symptoms further and resulted in this devastating complication. Yeah, sure.
Modulate the immunosuppressants.
Okay, fine. So in fact, if you look at the recently published literature on the management of this, the recent 2001 guidelines would say that this is from adults only, where the remission would last for 3 to 6 months, and typically the maintenance therapy would last for 18 months. But this holds true for adult population. But in pediatric PAN, probably the maintenance it will extend a bit more. If you look at the European guidelines, then it will extend from somewhere around 18 to 36 months. And one good thing about PAN among all vasculitis is that if timely initiation of therapy is established, in that case, probably the outcome is good as compared to the other vasculitis like incarcerated vasculitis.
Dialysis dependent now, and so in fact zero kidney function going to be an issue, even transplanting him at some point in time if he was to survive this. Clearly he's we have had so many episodes of sepsis,
Yeah.
antifungals, antibacterials and so on, and giving immunosuppression has been tough. I don't know, and clearly there is so much damage that's there that it's going to be a challenging thing, later. So I think it's going.
Yeah, so even we are struggling with the challenge of carving out the right path when to initiate the immunosuppression, because we are not yet able to give it among the ongoing sepsis and the penias that we are struggling with.
Status and with the gut not being available to an extent, renal failure, limitations of parenteral nutrition. I think that's a challenge which is going to further compound the entire story. It is absolutely emaciated kid, hardly any muscle mass now. So I think once you put that in perspective, a lot of other things I think would make it even more complex, and therefore nutrition would have to be one major component of the entire management. They won't be able to pull through it.
Exactly, absolutely agree, sir. Any further questions or comments? I would like to thank the entire team who has helped us in managing this case, and still we are managing this. Thank you.
We see about 4 or 5 cases in a year, and recurrences are even more rare. So to learn about how to manage, how to detect recurrences and be aware of it in pediatric population, this is the aim of the. So Dr. Chandramouli, our junior resident, will present the case, and Dr. Nilay will carry on with the discussion.
Good afternoon to all. We are presenting a case of a patient with pheochromocytoma. In 2012, this child was 9 years. He presented with complaints of increased water intake and increased frequency of micturition for the last 2 years, and used to drink around 16 liters of water a day. There was also associated history of sweating and palpitation, and no other significant history, no history of any head injury or elevated blood sugar. On examination, vitals were stable except the BP. He had hypertension with BP more than 99 centile, and no other clinical findings and no other stigmatas of neurofibroma or any familial illness. On imaging, there was bilateral suprarenal mass with Dotanoc uptake. The detailed radiology discussion and nuclear medicine discussion will be followed later. Both plasma and urinary norepinephrine levels were raised. Genetic testing for VHL was negative. For hypertension, phenoxybenzamin was started, gradually titrated up, added amlodipine and propranolol. Right partial adrenalectomy and left total adrenalectomy was done. In both the sides, the tumor was around 4 into 5 centimeters. The histopath will be discussed later. Post-operatively, the patient was started on steroid replacement and amlodipine, but gradually it was titrated and tapered off over a period of 6 months. On routine follow-up from the period of 2012 to 2016, patient was clinically stable with normal findings, and investigations were normal with serum metanephrine and non-metanephrine and urinary metanephrines were normal. In 2017, patient again presented with intermittent palpitation and excessive sweating since December 2016. This time there was no history of any polydipsia or polyuria. Again, patient has hypertension with orthostatic hypertension also present this time. On imaging, the left renal, hilar and para-aortic mass was detected with both Dotanoc and MIBG uptake. Again, urinary metanephrines and plasma metanephrines were raised. He was started on phenoxybenzamine, gradually increased to change to prazosin. Metoprolol was added and amlodipine was added as well, but the BP was not controlled initially. Finally, left paraortic tumor was excised in 2017. This time it was around 4 into 3 centimeter hard tumor in the upper pole of the left kidney, and there was another mass in the infrahilar region around 2 centimeters. In the post-operative period, during the surgery, there was no evident injury of any renal hilar or renal vessel, but in the post-operative period, patient had still persistent hypertension, which was controlled with amlodipine and prazosin. So imaging evaluation is done to detect the cause of this persistent hypertension, and it revealed left renal artery occlusion. And renal dynamic scan was also done, which suggested poorly functioning kidney. In view of this, left nephrectomy was advised, but the patient refused at that time. Patient was started on ACE inhibitor, ramipril, and on follow-up, the patient was stable with control of blood pressure with amlodipine, prazosin, ramipril, and metoprolol. Similarly, the urinary levels of normetanephrine was normal within the period of follow-up from 2017 to end of 2021. But in 2021, patient during the follow-up again presented with increased serum normetanephrine. This time the patient was asymptomatic, but BP was still raised on the higher side. On clinical examination, again no lump was present. On imaging assessment, again the left paraortic mass was present with increased uptake on Dotanov and PET scan, MIBG. This is the graph of plasma normetanephrine in 2021. Genetic analysis was again done due to this is a recurrent tumor and the cause has to be determined. So before it was done, it came negative, but this time an exon sequencing was done, and it was found to have a heterozygous missense mutation in the exon 3 of VHL gene with replacement of proline instead of leucine. Again, excision of this tumor was done, excision of the left paraortic tumor and left nephrectomy this time. In the post-operative period, patient was initially managed with hydrocortisone and antihypertensives were gradually tapered down and amlodipine, and patient was discharged on amlodipine. Now the imaging part, the radiology part, the nuclear medicine part and the pathology part will be discussed by our colleague.
Good afternoon, everyone. So we have the imaging investigation starting from 2012 up to 2021. So this CCT abdomen was one of the first investigations to be performed, and in the axial CCT abdomen images, we can see that there are bilateral heterogeneously enhancing suprarenal masses. So we do not see the normal adrenal, however, we see these masses bilaterally in the place of the normal adrenal gland. These are also seen in this set of images. In the coronal images also, we can see these oblong shaped masses in the bilateral suprarenal locations, having some non-enhancing areas and other avidly enhancing areas. Based upon these features of the bilaterality and the suprarenal location as well as avid enhancement with some non-enhancing areas, we did keep a possibility of a hypervascular tumor such as a pheochromocytoma, bilateral pheochromocytoma. Then to rule out any multi-system involvement, MRI brain was done. And in the sagittal T2 and the sagittal post-contrast images, we do not see any evidence of any lesion in the cerebellum or in the cerebral hemispheres. Then to rule out any involvement of the pituitary gland, we did a dynamic MRI of the sella in which we saw the normal pituitary gland without any focal lesion or any mass. So then the patient was operatively managed and the patient was fine for the next few years. Then the patient again managed with similar symptoms as the index presentation in 2016, and the imaging was performed in February 2017, which was the MRI abdomen. And in the MRI abdomen, we do not see the right adrenal gland. However, in the place of the left adrenal gland, we do see a bilobar kind of lesion on the T2 weighted images. It showed intense diffusion restriction on this trace diffusion weighted images and in the ADC map. The coronal BTF image, we can see that there were two lesions. One of the lesion was left suprahilar in location, and the other one was a small nodular lesion in the left infrahilar location, which was sandwiching the left renal artery. So this lesion was enhancing on the arterial phase, showed even further enhancement in the portal venous phase, and showed mild enhancement in the delayed phases. So the lesion was quite similar to the index lesion that we had found, and based upon these images, we suggested a diagnosis of a recurrence of pheochromocytoma on the left side. And the patient was again operatively managed, and the CT was performed in April 2017, in which we do not see any evidence of recurrence. However, the interesting finding was that the left kidney was hyperperfused. There was no enhancement of the left kidney, and it was small in size with some perinephric collection. In the arterial MAP images, we can see that this is the right renal artery. However, we do not see the left renal artery beyond this stump at the origin. Also, we see a small thrombus in the left renal vein. So these were the various changes that were seen in the post-operative period in April 2017. An MRI was also performed in September 2017, in which again we do not see any evidence of recurrence in the left suprarenal location or in the left or near the left renal hilum. However, again we see this left small left kidney, and whereas the right kidney is normal. And on the right side, the interesting finding is that the right adrenal gland is prominent on the diffusion weighted images. However, it did not show any significant enhancement or washout. And the patient was apparently fine for the next couple of years. And then again, an MRI was performed in November 2019, in which we saw a T2 hyperintense lesion in the left para-aortic location in the retropancreatic region. This was a well-defined T2 hyperintense lesion, which again showed diffusion restriction. And on the arterial phase images, there was a mild homogeneous kind of enhancement, which increased on the portal venous phases with mild washout in the delayed phase. So again, we saw a lesion in the different location, that is in the left para-aortic location, having similar characteristics as the index lesion. We again suggested a possibility of recurrence of pheochromocytoma in the left para-aortic location. This was a scan done outside in October 2020, which showed that the lesion in the left para-aortic location had increased in size. This is the T2 weighted image showing the T2 homogeneously hyperintense lesion, which showed minimal enhancement on the arterial phase images and on the portal venous phase images. The last set of images we have is of August 2021, in which a contrast enhanced CT was performed, in which on the non-contrast CT we see that there is a hyperdense lesion in the left para-aortic location, which shows minimal enhancement on the arterial phase images. However, the lesion is almost homogeneously enhancing on the portal venous phase. As compared to the previous scans in 2019 and 2020, the lesion has increased in size. However, it is still well defined and does not show involvement of the regional organs. So this was a pheochromocytoma, which had again recurred and is increasing in size. I'll call my colleague from nuclear medicine to discuss the scans. Thank you.
This is the Totonoc PET CT scan from 2012. I could not retrieve the original study, but as you can see, there are bilateral adrenal masses, which are suprarenal masses, which are showing mild Totonoc uptake in the scan. Then this is the 2017 Totonoc PET CT, which shows a well-defined soft tissue density mass in the left para-aortic location, which also showed very minimal Totonoc uptake. However, on the MIBG scan, it showed increased MIBG uptake, suggestive of a pheochromocytoma or a paraganglioma. And this is the renal dynamic scan 2017, which shows that the right kidney, the perfusion as well as the uptake in right kidney is preserved, and it has a non-obstructive clearance, as can be seen in this graph. However, the left kidney is faintly visualized with less than 10% function. This is the post-op images. This is the Totonoc PET CT, which did not reveal the para-aortic mass which was seen in the previous scan. And MIBG, which was done around the same time, also was normal. There was no MIBG avid lesion. Then this is the MIBG scan 2019 October and 2020, which again showed a MIBG avid lesion in the left side, to the left side of midline. These are the anterior and posterior images. And this is a 2021 Totonoc PET CT, which again shows a para-aortic retropancreatic, well-defined soft tissue density lesion, which shows increased Dotanoc uptake, suggestive of a paraganglioma or a pheochromocytoma. This is the 2021 renal dynamic scan. In this, the right kidney appears normal, shows normal perfusion, uptake, and non-obstructive clearance. The left kidney, which was faintly visualized in the 2017 study, is no longer visualized, suggestive of a non-functioning kidney with negligible function. I would invite a colleague from pathology to discuss.
Good afternoon, everyone. I'll be discussing the histopathology of the tumor mass which was resected in 2022. So we received a tumor mass with left sympathetic chain along with left nephrectomy. So grossly, there was a tumor mass associated with the nerve trunk, and kidney was a non-functional kidney, simple nephrectomy. So this is showing a tumor which is composed predominantly of large cells with on higher magnification, we can see these are large cells with pale eosinophilic cytoplasm, which are arranged in nest, which are separated by thin vascular spaces, and these cells have round nuclei, which are showing conspicuous nucleoli and vesicular chromatin. So significant mitotic activity or necrosis were not seen. So with this morphology, our differential would be a neuroendocrine tumor, which is of low grade. And can see under lower magnification, the tumor was well circumscribed and was associated with the nerve trunk with a ganglion as adjacent to the capsule. So this is the areas of cystic degeneration within the tumor. So we with this morphology and so as it was associated with the nerve trunk, we called it a paraganglioma. We have done immunohistochemistry for SDH to look for any genetic alteration. The SDH immunostain was retained with cytoplasmic expression, so implying there is no genetic alteration. This is histomorphology of kidney, which is showing no corticomedullary differentiation, and these are the sclerotic glomeruli with the remnant glomeruli you can see here, and the characteristic thyroidization of the tubules, higher magnification of the same. So there is an associated pyelonephritis. This is just an interesting finding which we saw. There was medial calcification in the larger vessels. So with this, we made a diagnosis of left paraganglioma in the left sympathetic chain associated with left pyelonephritis.
Good afternoon, everyone. I'll be covering the discussion part. So pheochromocytomas are rare tumors in the pediatric population, and they arise from the chromaffin cells in the adrenal medulla. Similar tumor from the extra-adrenal site will be called a paraganglionoma. The incidence is 0.3 per million per year, and the 20% of all pheochromocytomas occur in the pediatric population, and 1/3 of these are multiple. So the classical symptoms of pheochromocytoma will include diaphoresis, headache, and palpitations. However, rare symptoms can also include polyuria and polydipsia as seen in this case. 12% of the pheochromocytomas are malignant, and mutation in succinate dehydrogenase is a predictor of this. There is no clinical staging for malignant pheochromocytoma or paraganglioma, and surgery is the mainstay of treatment. However, before surgery, the medical therapy is initiated, which includes the alpha adrenergic blockade followed by beta blocking agents, and oral salt lading is done to expand the blood volume. So should the entire adrenal gland be removed, or should an attempt be made to leave some adrenal tissue behind? So if it is a primary unilateral adrenal pheochromocytoma, then total adrenalectomy can be done. If it is a bilateral tumor, or if it is associated with syndromes, then cortical sparing should be done. This is because the children will otherwise require the lifelong replacement therapy. However, if we do the cortical sparing one, then the remnant the adrenal can take over, as in this case also. 10% of the patients of pheochromocytoma have associated familial syndromes, which include either the von Hippel-Lindau syndrome, the multiple endocrine neoplasia syndrome,
and neurofibromatosis 1. In case of VHL disease, as seen in this case, it is an autosomal dominant hereditary and it is characterized by other tumors also like retinal angioma, central nervous system hemangioblastomas, renal cell carcinomas. In case of VHL associated pheochromocytomas, there will be a younger age of onset and it is more likely to have bilateral, multifocal and recurrent tumors. In case of sporadic pheochromocytoma or paraganglioma, 30 to 40% are associated with germline mutations, of which the von Hippel-Lindau is most common. In case of MEN2 syndrome, the medullary thyroid cancer usually precedes the pheochromocytoma, and in case of neurofibromatosis, there will be presence of specific skin lesions. So therefore, it is recommended to do the screening for the VHL and the succinate dehydrogenase genes, even in case of sporadic pheochromocytoma. The recurrence can be seen in 6 to 16% in case of pheochromocytomas, and most of the recurrence are in the contralateral adrenal gland as per the reported literature. However, 25% also occurred in the ipsilateral adrenal gland remnant. Tumor recurrences occur early within the first year, but there have been also reports occurring even 30 years after the primary surgery. And if and when the recurrence does occur, it is heralded by the return of hypertension and other symptoms. And the tumor size more than 5 cm and the presence of genetic mutations predicts recurrence. So therefore, recurrence is a common problem with familial diseases, and the symptoms need not necessarily be the same as that of the initial presentation. So if there are multiple recurrences, surgery is usually curative as compared to adults where the recurrences are often malignant. So how do we treat the recurrence? Surgery is the mainstay of treatment. Other modalities, if the surgery is not possible, may include iodine-131 MIBG therapy, chemotherapy with agents such as cisplatin, cyclophosphamide, dacarbazine, vinblastine. Somatostatin analogs, they provide the symptomatic relief, and the peptide receptor radionuclide therapy is also an alternative. So how do we follow up the cases of pheochromocytoma? If it is less than 5 cm size and if they are sporadic, the metanephrines, either urinary or plasma metanephrines, are done postoperatively at 1 month and followed by the repeat metanephrines every 1 to 2 years lifelong. If it is more than 5 cm or associated with multiple tumors or with inherited disease or the genetic mutations, then the metanephrines are done at 1 and then 6 months postoperatively and then annually for lifelong. And in this inherited diseases, imaging is also recommended. So pheochromocytomas are considered to be a curable cause of hypertension. But in case of individuals with renal artery stenosis or primary aldosteronism, they lose the ability to reverse the hypertension because of the secondary vascular changes. So in our case, there was renal artery stenosis which was a cause for the persistent hypertension. So I'd like to conclude by saying that long-term follow-up is necessary in all pheochromocytoma patients. All patients should be offered genetic testing given the high rate of inheritance in pediatric population. And all patients should be followed lifelong given the risk of recurrence. And multidisciplinary approach comprising of a team of experienced nephrologists, endocrinologists, genetic counselors, radiologists and surgeons is necessary for the efficient management. Thank you.
Yeah, there are two important points in this case. One is whenever there is a bilateral adrenal mass, must think of syndrome. Is mostly bilateral adrenal mass are syndromic, unlike the unilateral, which is benign, which is once you take out, patient is cured, and a unilateral adrenal coming back again is called malignant pheo, which is seen in adult, not in children usually. Then second, the biochemical hints. If you have got normetanephrine high, then metanephrine, think of paraganglioma, then pheochromocytoma. Because you need to convert, norepinephrine has to be converted to epinephrine by methylation. So it was the epinephrine which was discovered first. And when they see the structure of epinephrine and norepinephrine, there was no methyl group in norepinephrine. That's why it is called norepinephrine, though it was discovered later. So it is for methylation of norepinephrine to epinephrine, you need the high concentration of steroid hormone, because that enzyme that converts the SAM, which is a methyl donor, to methylation of the norepinephrine to epinephrine, which is not present in the other part of the body. So anything which is other than the adrenal gland, so there you will see norepinephrine level will be high, so leading to normetanephrine. Whereas if you see norepinephrine high and syndromic, you think of paraganglioma and you do STH E or D mutation, mostly it will be positive. And Hippel-Lindau syndrome is also, VHL is number one cause of. So these are the 3 points which are must remember in this case.
Yeah, difficult also because though surgically we didn't have any injury to the renal vessels in the second surgery, but then we realized post-operatively that the kidney has become non-functioning. And though the father is a doctor, though we offered a nephrectomy so that the BP can be controlled and long-term effects can be prevented, but it was 5-6 years before they gave the diagnosis. The second recurrence was diagnosed during the pandemic. It was a small tumor. The endocrinologist felt that we could observe and wait for the pandemic. By the time we posted him for surgery, the second wave came. So again, the father was very apprehensive for getting surgery done, and so it got delayed to this year. And hopefully now the child should be okay. The importance in pediatric bilateral tumors is if we can preserve part of the adrenal, because in children being without adrenal on replacement therapy is okay, but intercurrent illnesses like diarrhea, pneumonia, that requires um, upgrading of the steroid doses doesn't happen in the periphery, and we can lose the child because of adrenal crisis. And so if we can preserve, then we try to preserve in children at least. Can go in any number of times. It becomes more and more difficult, but we can go in any number of times. Yeah. I don't know. I mean, the adrenal we left is on the right side, but as Dr. Bal is saying, it's a paraganglioma now. So the adrenal we removed. Yeah. Bladder, everywhere it is. So Rajiv has a huge experience of more than 400-500 cases.
It's not 400, it's just about 300 so far. I think you've done an excellent job. We've seen a lot of paragangliomas. In fact, we just done one yesterday. Para-aortic paraganglioma, including surrounding the left renal artery. And she continues to have hypertension today. So I'm going to get a Doppler on her because it's either a renal artery stenosis, which we thought existed preoperatively, or she's developed a thrombus. We saved the artery. We've seen it pretty well. We did it laparoscopically, but she has hypertension today itself. She's back on the 3 drugs, on nitroprusside all night. So we'll probably have to check for renal artery stenosis there. We find them left more common when it's paragangliomas, probably because the chain runs along the aorta. That's why we probably find it more common on the left. The adrenal FEOs we typically find more on the right. So the FEOs that we've done are more on the right. The paragangliomas that we do are more on the left. And like you said, we've seen them in the bladder also. We've resected some. And your point on metanephrine is absolutely valid. So when you have a high metanephrine, you suspect a paraganglioma, even if it is located suprarenally. So we've removed tumors from what looked like the adrenal, but when you dissect, you know that this is not an adrenal gland. You can make out the dissection is completely different for a paraganglioma versus a FEO. And although anatomically they are where the FEO should be, they actually turn out to be a paraganglioma. So we've had that also at times. Otherwise, I mean, it's an excellent outcome. We might come back. We'll take over the next time. He's now more than 70.
He is just nearing 18 years. So now we'll hand over. So we have another case like this who's had 3 recurrences, has been treated by you by 2 different modalities of nuclear.
First in the world to publish an actinium, which is alpha therapy for paraganglioma. We have a small series, 9 patients, but this is the first world with actinium, which is alpha therapy. And we have got very good result. Just published last month in European Journal of Nuclear Medicine.
Because it's not receptive. And then with the second.
But in this patient, the MIBC uptake was not very great.
Not very. And then moreover, it was very easily resectable. So we said
we always take such.
Right. Okay. So if no more questions, then thank you. Yeah, please.
Most important part of your team.
That is true. You can't do anything without them. So all these, yeah, right. So I think all the three times it was done by Dr. Rajeshwari and her team of people. This is entirely from pre-operative period they manage. Right. Thank you.